especially after lunch, but we wanted to give the cohorts a chance. I'm sure it's come up. It's come up in my small group, the discussion about missing data. So I'm wondering if it came up in some of the other small groups. But we have a great panel here who's going to be, I'm going to give just a quick introduction about some things, and then we're going to get right into panel discussion. But missing data, some people are like, is it really a problem? So when we have missing data in our research studies, from an analytic point of view, we have to figure out what we're going to do, right? And you've probably heard of the word imputation. But even with missing data, we always have to make some assumptions. So in this typical example, how would you fill in the missing blank, right? So if I was your supervisor and you told me that your wife is not working today, right? I might not really have an issue with that. But if you told me your Wi-Fi is not working today, maybe you're not going to be as productive at work. So it matters how, we always make assumptions into how we're going to fill that missing data. And so when we think about clinical research, think about where the problem starts. So a simple example, right, you have a study with a certain follow-up period, let's say a 12-month follow-up, to obtain the primary outcome. This could be a change from baseline. It could be whatever your point estimate is at 12 months, or it could be a binary outcome at 12 months of success or failure. That participant that's enrolled in your study misses their 12-month visit, right? So now you don't know what their outcome is. You start mixing this with whether they were compliant with the treatment, did they have side effects, and you could have a real mess of trying to figure out what would that endpoint have been if I actually captured that 12-month visit. There's so much literature on this topic of missing data, particularly in clinical trials. Statisticians have dissertation after dissertation on this topic, and we still continue to try to understand better ways of treating missing data. But one thing that remains consistent, right? So here's a New England Journal paper back that was published in 2012, and from very famous trialists and researchers, and basically in 2012 they said there is not an easy fix for missing data at the analysis stage. Design and carry out the trial in a way that limits the problem of missing data. That was the conclusion in 2012. And then I came across this paper in Circulation in 2025 that the conclusion, the best strategy is to minimize missing data from the outset of the trial, right? And so when you all have been working really hard on your research questions, your specific aims page, but I'm wondering how many of you have really thought through the implementation part of your trial, thinking about, is that the right endpoint? Am I going to be able to capture that endpoint in order to measure my treatment effect? There's a lot of different causes for missing data, right? You might have someone just arbitrarily missing a visit. You know, we're doing a prospective research study. These are people who have daily lives. They might have missed the bus. If a child might have gotten sick or something, that's an arbitrary missed visit. But you might have someone who withdraws from the study, or maybe they experience an adverse event, and so you miss a visit. But what if that adverse event is due to the intervention, right, that you're studying? Let's say that this also can happen, right? A participant attends the study visit, and the research team forgets to do the measurement, or maybe you needed some device and the device malfunctioned that day, so you don't have that data. Or maybe the study team, God forbid, changes the case report forms in the middle of the study, and now you can't retrospectively go collect that data. So there's a lot of different reasons that you have to think through when you're designing your study with your team to say, okay, what are the factors that could go into me not being able to collect my data point? And why is this a problem? The biggest problem is because anytime we're making those assumptions about what would have happened if we actually collected the data, it can lead to bias, right? And that really complicates the analysis, right? It goes back to the participants. Participants who provide data, maybe they're different than the people who don't provide data, right? Regardless of which treatment arm you're on, right? So you have to think about, some people are like, oh, I'm just gonna ignore the missing data, right? I'm just gonna do like a completer analysis. You start to really break down that whole random sample that we're trying to achieve with a prospective clinical trial. So don't think that your analysis can fix everything, right? There are certain assumptions we have to make with missing data. And it really depends on why it's missing, but sometimes you don't know why it's missing. So now I want to turn it over to our panel. I have a few questions for our panel members. First one, so can my panel members, based on your experience, provide advice to the audience on how you would minimize missing data at the design stage? Who would like to go first? And you can use examples from your experience.
Well, let's see. Let's see. One thing I would make sure that everybody's always aware of is there is a difference between withdrawing from a treatment as opposed to withdrawing from a study. So if a patient ever comes, I find everything intolerable, I don't want to, anyway, whatever they don't want to do, the first thing you ought to try to get them to do is, can I go ahead and collect the measurements? So can I go ahead and still collect your data? However you can make that happen, that's very valuable for you to have, just so that the data exists. Obviously, they're not compliant with the arm, whatever the case may be, it's still better than it's being missing. So certainly I would try never to have people withdraw from your study. Obviously, you can't take them hostage. I will say I have seen real examples of people who have hired private investigators to track down patients. So, I mean, if your endpoint is mortality, that's pretty easy to assess if you can lay eyes on somebody. So I have known people actually try really hard to get data under certain circumstances. Another thing that you should take care in how you pick your endpoints. So some endpoints, the data is missing, and other endpoints it's not. So for example, we do a lot of endpoints that are what you call free day endpoints, which essentially means you go in for some condition, how many days are you out of the hospital during some follow-up period, 30 days. If you get out quickly, that's better than if you stay in the hospital a long time. Are you free of vasopressors or various, anyway, you could be free of a lot of things depending on the indication. One thing that will happen to people, of course, is that they can die in the hospital or die after that time. And so you don't want to be in a situation where you say, I'm going to define my endpoint entirely on the number of days that they're in the hospital, and suddenly somebody dies and your endpoint is either not defined or it's missing. Usually in those cases, we handle it fairly straightforwardly. We just assign that if you die, the endpoints is -1. It's essentially the worst possible outcome. We may do some kind of ordinal analysis to handle that, but all that's possible. This happens, it's more difficult in things like ALS. We do a lot of functional kinds of endpoints, and people die during the follow-up, and the question is obviously they're not going to provide a functional measure. It would be good, I don't think we have those kind of endpoints, but ways to think about what is the actual utility of these measures. So instead of having to do it separately in the analysis, it would be good to have these things defined up front. I don't think we've done that completely, but those are the kind of things I would think about.
So I would say thinking about the complexity of your trial and how that could relate to missingness. If you have these visits that have battery after battery after battery that take hours, your participants may not want to come back. And I think sort of similarly this is more in the multi-center setting, but if the procedures are overly complicated or the visit windows are confusing, I think sort of like your research coordinators and staff could forget to schedule visits and that sort of thing. Another thing to consider is I think there's specific things that can happen in open label studies that you should think carefully about. For example, you could have missing data not just on the endpoint but on baseline data. So if you're randomizing to an intervention versus usual care, and someone gets randomized to usual care and they drop out immediately, you can't even really compare baseline characteristics to see if the people who drop out are any different than the people who stay in.
They said everything I was gonna say. No, I think it's really important, what Kurt brought up, it's different withdrawal from treatment versus withdrawal from the study. So I have a lot of exercise trials and rehabilitation trials, and across all the centers and all the sites, we have teams that will say, well, they weren't exercising anyway, so, we stopped following them so closely, or, so don't create your own missing data, in terms of, so if they're not participating in the intervention, that's perfectly fine, you should document that, but you should still continue to follow them. Also, my study teams have a really bad habit of collecting 26 secondary outcomes, no joke. And so that's a lot of information, and it doesn't take a scientist to look and say, a depression scale, I just filled out, this other depression, so, make sure that you're really honing down what you want to collect, and that it's really important. I would also say, really know your population. I work on studies, our Parkinson's trial, we have 5% attrition at 6 time points. I mean, it is really small, like really know so that you can inflate your sample size to account for the missingness, so that's on the design stage. And then I have other studies in ACL reconstruction, we're mainly dealing with 25-year-olds, and we have 30% missing data. So really know that going in when you're planning for the study, and what it's gonna take to get them to complete surveys, remote surveys, RedCap, you can email people whatever outcomes, they can fill things out, text reminders, and so on. Pay a little bit more for really experienced staff who have great personalities and can retain individuals in a study. Sometimes we don't have the budget to do it, but it's worth it to, I don't know about your universities, but go that additional class up in whatever that coordinator role is, and pay, get the best people. Because especially if you're dealing with a multi-center study, they're gonna be the standard for what your sites are gonna do. And so, whatever they communicate to those other coordinators, that you want that to be best practice and how they retain people. So don't create your missing data. And then I guess the last thing in terms of the design, that's what your feasibility studies are for, so that you can really learn like where the missing data is going to happen.
I also made notes and reread them, but I would say for a lot of other reasons too, involve biostatisticians early, because we have dealt with all of the missing data reasons, so we might be able to see things that you're not thinking of that could help reduce missing data from the beginning.
Just a quick question. Can you explain, like, if I've got a person who's dropping out of the study because of family burden and it's their disease is advanced, what can I tell them about why it's so important for them to come back to collect a little bit of extra data? Like, what does that matter to the big study overall? Can you put that in terms I can tell a person?
So, oh, you go first.
Well, I mean, I think we want to have conclusions that are generalizable, and so the person who's going through that experience is representative of that patient population. So I think it's like, I guess, appealing to the altruistic sort of, for the greater good type thing, because if our conclusions are drawn in only the people who don't have those types of experiences, they're not going to necessarily be right, but they won't generalize to those types of people.
Yeah, and I actually have a specific study where we're following folks with Barrett's esophagus, and then we want to see if they progress, but they have to come in for the endoscopies and the eradication therapy. And so they consent to be in the study, they're fully aware of the follow-up period, and it's up to 4 years. So we definitely have had some participants come back and say, this is just too much, really just too much. So our clinical investigators, when that happens, they have the discussion with them saying, we understand, you don't have to come back for these eradication therapies, but can I just call you? Can we just check in on you, and you can still participate in the study? Because we know at some point they consented to be in the study, not knowing if they were going to benefit on an individual level. But that conversation between the clinical caregiver and the participant is so important, just as much as that consent process is at the beginning of the study.
this.
Oh, do you need a microphone?
I wanted to
I still have more questions from our panel.
I just have a question. I think
I wanted to add something I think is very relevant to the students or trainees, like in the course with respect to this, and that is another thing that hasn't been touched on that we see commonly in neuronics and other studies is don't assume that other sites will do the study to the same rigor that you will do it. That's where you get into a lot of problems with missing data. I mean that on two reasons. One, you would be amazed at how many times we're designing a study with an investigator and they tell us their control arm is standard of care. And we bring in 20 other sites and it ain't standard of care, right? So that's one. And so then you're adding heterogeneity, which also has missing data. Number two, no other site PI will care about the study as much as you do at your site. And so you have to recognize that. You may have all of these things in place at your site, but your 19, 30, 40, 50 other investigators will not. So you also want to have procedures in place to make sure that you're not just minimizing missing data in the perfect scenario, like what's at your site, but also that you're being a little more lenient in thinking of what could happen at other sites. And this also gets to like the burden where maybe your site could have people do 30 or whatever, because that's your life. You have 5 people who could do that. Other sites won't.
No, that was perfect, because it kind of goes into my next question, which I think that's gonna tie in, is because it kind of grays it, right? There's the design part, we talked about endpoints, we talked about thinking about your follow-up period. But then you're in the implementation, and you guys kind of talked about it, and what Chris just mentioned too, that's part of the implementation. Don't think that all your sites are acting the same way.
Yeah, well, and I guess just to take a step back really quickly, I think the other thing too is sort of marrying things that everyone else has already said, but I think if you have a population where those types of patients are expected, to Charity's point of view, think 30% are going to be missing, you may need to rethink your endpoint altogether, right? So something like Kurt was saying that marries sort of, death status and functionality, but if it's something that you don't expect you're going to be able to have people come back, maybe it needs to be something that can be collected over the phone versus something you have to be face-to-face with the patient. Medical record, death registries.
So I guess there are other aspects now of the implementation that you could share as words of advice.
Well, I'm not going to be the best person at this, but one thing I would say is you don't want to wait until the end of your trial and then realize you had missing data. This is something, if you're doing this for 3 years, this should be an ongoing process of, here are all of my sites. This is hard to do, and Christine and Terry are going to know more than I do about this. But the notion of sites having to get their data in, a lot of sites are, hey, I'll wait till somebody really makes me do this or the end of the study or so on, and then I'll grab the big pile and try to get everything entered or so on. Having this stuff go in a timely manner so it can be monitored and recognized, hey, site X is letting me down, you need to know that site X is letting you down. And missing data is one of the ways they can let you down. They might not enroll any patients. It's probably worse if they enroll a bunch of patients and then don't collect the data on them.
Yeah, so I think that's a great point. I think one of the things we try to do is look at a variety of site performance metrics. So that would include things like data timeliness, but also presenting retention to the sites and sort of at their site, and then overall, I think helps just drive the point home if there is an issue. I think if you have flexibility sort of in your budget, trying to really get at the root cause of what the issue is. I hear often that there are issues with transportation or parking or that sort of thing. So if that's a barrier, can things be shifted around such that you can pay for an Uber to get the participant back to your site? And then I would say, especially as we're shifting to more pragmatic approaches and technology advances, I think the relationship between the site personnel and the participant is really important. building that is gonna encourage them to actually continue to follow up in the study.
Yeah, so, we run we call them quality control reports, but it's all of our data monitoring, for all of our trials, sometimes monthly, every 2 months. But there's an independent data team, not your project coordinator, but an independent data team that's running these reports and submitting into the team. Not if there are outliers in your data, but if it's just present, so do you have 3 months, 6 months, 9 months, 12-month outcomes on people, even if it's just a single center study? So you're expected to have them, do you actually have them? So that's common, and I think it's really important that you have an independent data manager, even if you're running a single center study, that it's not the person that's supposed to be patient facing, and then that way, they're not in the data and then also monitoring the quality of the study. So yeah, I think the QC reports are really important in terms of the implementation, and then also training the staff. We've had a lot of turnover in staff, but making sure that everybody knows they don't have to be a statistician, but they understand intention to treat and follow up and sticking to the protocol and not deviating from the protocol. So we can't assume just when they come on board that they're actually trained on the protocol, and I think that's really important from the start.
Can the panel members?
Add to that a minute? Oh.
Come sit.
Yeah. Just to follow up on that though, often at the site level, they don't understand the difference between all the data versus when you get to the intention to treat part, that kind of leads into that discussion of, the primary endpoint. That needs to be or you have 29 things to do on this particular day. Make sure the thing that doesn't get bumped is the primary endpoint or the secondary endpoints. And there's ways that you can present that to people so they understand that difference. And that's going to help a lot with your missing data, because a lot of it is just stuff that you may or may not
And
know.
also document, so we have protocol deviation, so we have our sites document, maybe they got the primary outcome, but they couldn't go do the VO2 peak test that day because the person they weren't feeling well or had a cold or something along those lines. So just document, and that's informative for the statistician, so we know why they don't have their blood pressure assessments that day. And it's, partial data collection is perfectly fine as long as you do the primary outcome.
I'll just add one more thing. I think the training piece, I think we need to recognize too, especially this is more of an issue, I think, in multi-center studies, but overall, every time we hear something, we learn a little bit more, right? So I think just because you did it at the beginning of the study, I don't think you should believe that sort of was good enough. I think there should be continual retraining, revisiting certain things in the protocol that are important.
Can the panel members make a comment about establishing visit windows? I don't think people think about visit windows. Say a few words.
I don't think about it because it's our default.
Right, but I don't.
It's in every flow diagram in our protocols, it's plus or minus. Yeah.
How you set them.
Oh. Well, it depends on the time point, if it's a 3-month, then it's probably plus or minus 2 weeks. And then if you're out to a 24-month, then it's plus or minus 2 months. So sort of depends on that's our approach, depends on how far out it is.
Yeah, maybe telling the trainees why it's so important. Should not forget about it.
Right. Well, so I think first of all, you've selected your timing for your endpoint for a reason, right? It reflects something that probably has some relevance. And so I think thinking through what window around that endpoint timing would plausibly still reflect what you're intending to measure is important. You also want to make sure that your windows are wide enough that you're not just getting a protocol deviation for every single time that you have a visit. Another thing that might be important to think about, depending on what your outcome is whether sort of like going far back is a good reflection of what you're intending to measure. If you can think of like a survival type endpoint, it might not make sense to measure it super early, so maybe the window needs to be heavier on the other end.
Okay, can I think I know where you're going with this.
Then we're gonna get into the next phase.
Chris,
there's a chair.
Well, no, I think this comes back to the point that I made before about thinking everybody will do it. In most of our studies, the windows start extremely tight because the investigators want that to be tight. And then they start the study, and 6 months in, the deviations are flowing like wine. And then they realize you have to relax that. So I think when you're doing the windows, you can't let perfect be the enemy of the good. That's one. The other thing that I will say is there's also a temptation to go too far in the other way. If you're seeing people, say, every 6 months, and you end up letting your windows basically be 3 months on each side so that they touch each other, you can end up in a situation that makes absolutely no scientific sense, where your 3-month visit and your 6-month visit are on back-to-back days, where you're basically measuring the same thing for 2 different visits. So there is, I mean, you want to pick a window based on the science, but you also want to allow it to be flexible, but not too flexible, right? And part of that is a study-specific question of how far out is the data still meaningful in terms of the comparisons versus how far out does it become so obtuse that you're basically adding more noise than you're getting for what you're collecting. Where it's weird, but in some ways bad data is worse than missing data, because bad data is wrong. Missing data may or may not be wrong depending on your assumptions.
I don't know if this is general practice for everyone else, but something I typically do for some of my studies is the protocol defines a window where you're asking your participants to come back. That's your target date for the visit. But then we have these secret windows in the SAP where we say, okay, we really want, it's still a protocol deviation if it's collected outside of my plus or minus 10-day window, but we're going to analyze it as long as it's within plus or minus 15 days.
Good, thank you. Okay, moving on. So we've been talking about ways, there are ways you can prevent missing data, right? So just think about that in your design and implementation. But we also know that I don't think I've ever been involved with a clinical trial where I've had 0% missing data, right? Something always comes up. So then we start to get into the handling methods. And you're going to want to talk to your statistical team when you're doing this, but I want our panel members maybe to get some words of advice on the different handling methods. So I'm going to kind of go through a list of them, and then you all can give your gut reaction. How about that? So the first handling method, this would be the complete case only, right? So this is where you're saying, I'm ignoring my missing data. When can you do this? How much missing data is minimal enough to ignore? I'm going to turn it to my panel members to give some words of advice, please. If you're doing a complete case analysis.
So I would say there are very few situations where that should be your primary, regardless of how much missingness there is.
Do we have repeated measures? What's a complete case?
Complete cases, you're analyzing your primary endpoint with only people who have actually collected.
All data, or all data?
The data,
They only have
the
that
data
time
you
point
have
under
is the data you need that you're analyzing. So let's say it's a 12-month primary endpoint. Or can you ignore the people who don't have the 12-month endpoint?
So I'll expand the question a little bit more. No
Sure.
one's going to answer the question you asked.
Right?
So that there's an issue of what you consider your primary, and also what you're going to have to do to back that up in terms of your sensitivity analyses and so on. We do see a few complete case. We actually probably see more than we would prefer. So I work primarily in industry and primarily in phase 3 for what it's worth. The complete case, certainly you need a very small amount of missing data. You'll almost always be asked to do, at least by FDA, I'm familiar with other things, you'll be asked to do what's often called a tipping point analysis, where they'll essentially say, if it's just, say, your endpoint's mortality, they'll basically go, here's how many missing data you had in the control arm, here's how many you had in the treatment arm. We want you to consider every possible way there were X deaths in control and Y deaths in treatment, and tell us which one of those maintained the conclusion. The hope is that it doesn't matter how the missing data came out, and you're fine. In practice, that graph is always, well, it's some that go both ways, and it becomes what's in FDA speak is called a review issue, which you never want to hear. And I will say, I have had one data set with no missing data. So, but the intervention was you got randomized and it was a spray-on in surgery and you got the endpoint in 1 minute. So, pretty easy trial.
Sounds good.
Anyone else want to comment on case switch? We can keep moving on. Okay. Single imputation methods, right? So you're replacing the missing value with a single value derived from, and you can derive it different ways. So on the screen, there's just a few types. There's something called last observation carried forward, which I'd like the panel members to comment on. Best worst case scenario. So if you're having a binary outcome, let's say success failure, are you giving everybody who's missing the worst case scenario? Are you giving them the best case scenario so they succeeded? Or are you, depending on which treatment arm they in, do like is the usual care or placebo, get the best, in your experimental get the worst? To be conservative, there's different scenarios of best worst case. You could also do like a median or mean imputation, so all of taking everyone in your population, taking the average and then using that to impute the value. Or there's also other things like called hot ducking imputation.
So nearest neighbor.
Oh, that's another, I didn't list all of them because there's a lot of ways you
I
can
feel
do
like I'm
single
confessing
imputation.
what I've used.
But tell me about when you would, maybe tell the trainees when you would use a single imputation, right? Because there's other methods out there too.
Yeah, so I think one thing that we've not explicitly said is that probably no matter what you're doing, you want to plan for sensitivity analyses, which basically means handling missing data a different way and making sure that your conclusions are consistent. So I think having those plans and being able to show sort of consistent inference is important no matter what. I would say, personally, I would feel comfortable with single imputation with minimal missing data. I don't really even know if I have a cutoff, but 5% probably feels comfortable. Whether it's higher than that, I'm not sure. So I guess the overall concern with doing single imputation is that you're treating it like it's a known value, and if you're doing something like the mean or the median, you're sort of reducing the variability of your estimate, so then your confidence intervals are smaller, your p-value is smaller, so you're concluding that you have more confidence in your estimate than you really should. Something like hot deck or nearest neighbor, I think, is preferred to me over some of the other options. In that case, you're selecting another subject from the data set that looks like the one that has a missing value on different relevant characteristics and assigning their observed value. And then I think some of the other ones, like best worst, I feel like belong more in a sensitivity analysis. So to your point, it's kind of like just trying to break it to see if you're still coming up with the same conclusion.
I think it also, you have to think about the indication. If you're doing a smoking cessation study, anyone who drops out of a smoking cessation study is somewhere smoking. So, that's what they're doing. Well, so in some studies, if people disappear, the reason typically they disappear because the follow-up was 3 years on my knee device, but my knee was feeling okay, and I just stopped going, but they may be in good shape. In other cases, people tend to leave, oncology studies, cancer got worse, a lot of times it's in the endpoint, they're considered progression, but they could also, I started feeling worse, I wanted to get treated, I went to another study, I went to something else, and you really have to think about who are you experimenting on, and when they leave, why did they do it? Was it for good reasons, bad reasons? If you're going to impute them in any way, that should be part of your strategy, at least acknowledging that reality. You're not really on the panel.
Yeah, I was going to say, can someone comment on last observation?
So I never use last observation carried forward. But when I first started working in Parkinson's disease, I think what they were originally using wasn't last observation carried forward, which is before a person goes on to dopaminergic therapy, and you would do a UPDRS, in our study, once they went on dopaminergic therapy, we used the drug naive value carried forward in the analysis. At the time that we did that study, that was our SPARKS phase 2 study, that was what was practiced in the literature, and it was essentially last observation carried forward. But the reason for doing that is once you took, you can take a person off meds for 24 hours to do an off-med assessment, but the thought was that they would never come back to what they would have been had they have not started medication. So it was, statistically, I always struggled with, I was like, that's just the last observation carried forward, but it was informed by the fact that you could never really get anybody back to what they might have been had they have not started medication. So there are certain practices that go a little bit against some of the things that the statistical team that might be uncomfortable with, but there are usually statistical reasons to do it.
I want to make a point going back, particularly to the single value imputation. That's, I think, something that the trainees should be familiar with, both in interpreting within and interpreting other studies. It's one thing when the data comes to you missing, and your statistician's imputing it. There's a sneaky way that data comes into clinical trials where that has actually been done before it ever gets to you or the statistician. It comes up a lot with biomarkers, right? If you're measuring any kind of lab value, whether it's a biomarker or a safety lab, and there's an above the limit detection or below the limited detection, it's not uncommon practice that it comes in where if it's above or below the limit detection, it comes in with whatever the upper limit or lower limit of detection is. If the data's coming to you that way, it has the single imputation problem, because those values could be anywhere below the limit, you don't know, and we'll have the same issue that Christy mentioned in terms of the bias and the variance, which is what plugging in a value as if it was known is, which inflates your type 1 error rate, which means you may see bigger signals across groups in that biomarker than you might otherwise see, and you might overinterpret the meaningfulness of that.
Okay, and there's, just one more question for the panel members. There's other methods, right? There's maximum likelihood-based methods, and then there's multiple imputation methods. Can you just, in 1 minute, summarize?
So I'm the Bayesian here, so I'll do the multiple imputation. Essentially, multiple imputation, the idea is that instead of filling in a value where you assume it's known, you know that there's going to be some variability. That missing value, it could be X, but it could be X plus some amount, X minus some amount. So the idea behind multiple imputation is you fill in data sets with a range of missing values, and then you basically, it's integration for us, but basically you look at the distribution of what the data sets would look like in order to fill those in. It's going to be more complicated, but it handles what Christy was talking about with respect to the variance.
Well, I think maximum likelihood-based methods, we're talking about having repeated measures. So if you measured your outcome at multiple points after baseline, this can be a good way to handle missing data. You're not doing any sort of imputation with that. You're just sort of implicitly handling it because you're using all of the data that you have in your model. So you're not filling in the blanks, but you're just modeling it directly, so I think multiple imputation, it has value. It probably is better than single imputation, but then you're making assumptions about the missing data when you're imputing it. So, if you're wrong about those assumptions, it's like you could just create bad data. So I think both of those have value. If you have multiple post-baseline visits, probably I would pick the maximum likelihood approach.
And I think our panel members already commented on this, but I think Christy mentioned it recently, was the importance of sensitivity analysis. So whenever we have these missing data, your analysis plan is going to have a primary analysis, and then you're going to see a paragraph in that statistical analysis plan of, and then we're also going to do X, Y, and Z, which, as Kurt mentioned, might be the tipping point. It might be other assumptions we're making, because there's always assumptions when you're dealing with missing data. Do the panel members have anything else to comment? Do it. Don't. Yeah. So the key takeaways.
Well, do it sensitivity analysis, don't have it missing data.
Right, avoid missing data. You really can't avoid it. If you come out of your study and you report in your paper that you have 20%, 30% missing data, that's way too high. We want to keep it like 5% missing data if possible. And even then we have to figure this out. So yeah, you want to avoid missing data, work with your study team, right, in the design and implementation to minimize it. And I love this meme that Chris shared. I had to stick it in the slide of Einstein. There are two types of people in this world. Those who can extrapolate from incomplete data. Hopefully everyone gets that. It's the sense of humor. Something's missing, right? Yes. Any other final words of wisdom from the panel members? Thank you so
Well,
much.
actually, there is one point we should make, though, I think, that just not to confuse.
I know, I think this is an important point. Everything we talked about is only valid if you don't have informatively missing data, which means the missing data is not because of what you're trying to measure. If you have informatively missing data, any of the techniques we talked about can be biased, and then you're in a whole different problem.
We kind of covered it a little bit,
Well, a little, but even maximum likelihood, multiple imputation,
But you can impute it as if it's not available.
actually you can't.
Okay.
I know, right? This will be a
Fight! Jerry, throw a chair.